we can make a difference. We can demonstrate that what we do is not visceral, not intuitive, not gut. Not that those things aren't important. They're good. It's good to have good clinical intuition. But you need to tie it to evidence-based practices and evidence-based approaches, because there's always the question of what happens if you're wrong. Expanding treatment capacity is one of our goals. We need to be able to do that, and NIATx is helping us achieve that, and process improvement helps us achieve that by increasing access and retaining people. We're using, to expand treatment capacity, our various, at CSAT, our various grant portfolios, including not only the state block grant, but our TCE grants. TCE funding supports grants to state and local governments, tribal entities, and a nonprofit organization, helping communities bridge the gap. Since 1998, we've had grants that targets American Indian, Alaska Natives, Asian Americans, Pacific Islanders, rural areas, methamphetamine abuse, e-therapy, grassroots partnerships, and minority HIV and other populations. I always like to make reference to e-therapy. NIATx is doing some very good work in this area. We need to think about how we can use the internet, telephones, Twitters, Facebook, whatever, to enhance our reach. We can't say, well, that's poor quality. No care is poor quality. And we've got large portions of our community that there is no provider. I was in rural Oklahoma. It cost me more to use a cell phone in rural Oklahoma than it did in Guam. I was talking to folks back home on my private phone. I got a $500 bill. I was using the same Verizon line in Guam. No difference in the bill. So we need to understand that. As the person says in rural Oklahoma, yeah, Dr. Clark, we tried to get to the treatment program if the roads don't wash out. We need to understand those realities. When you're up at the Arctic Circle in Alaska, hello? Well, we need board-certified psychologists and yada, yada, yada. I said, we can't even get a social worker up here. Can you help us with the models of care that we can get? As soon as someone gets a degree, they're gone. Can you help us deal with the people who have problems? So these are strategies that we're working with. Our TCE grants, we've awarded 97 new TCE grants, 49 HIV, 3 Asian American Pacific Islanders, 11 American Indian Alaska Natives, 9 recovery-oriented systems of care grants. This is in fiscal year 2008, and 25 TCE general grants. For 2009, we're funding up to 13 new TCE local ROS grants totaling $5 million. Our access to recovery initiatives, proven successful in helping to reach those in need of substance abuse services by expanding treatment capacity, by having a voucher system which some people are using to leverage their electronic health records. We can use new strategies. We can produce results. We can reach non-traditional providers. We can demonstrate that substance use is a whole community issue. For ATR 1, we had 15 grants to 14 states, 1 tribal organization. We saw 210,000 clients. We've got a PART score as moderately effective. For ATR 2, we have 24 grants to 18 states, 5 tribal organizations in the District of Columbia. And we're meeting our criteria. The program has proven to be effective in terms of creating a new foundation for building service delivery infrastructure, electronic voucher management that centralizes and streamlines complex activities across systems. It has expanded capacity resulting from a trained network of clinical treatment and recovery support system providers. It's increased efficiency, accountability, and quality services supported by training, policies, protocols, and administrative processes. It has an enhanced and expanded workforce, including many recovery-oriented peer support. These are some of the data that we have. I won't go into that because we've got a wide range of providers, but the key issue, we're tracking data. We want to know if you're making a difference. We will have an ATR 3. Hopefully your jurisdictions will participate. We're going to refine the efficiency measures to accomplish more benefit for the same amount of resources. Our project period will be increased to 4 years. We're going to try to get 225,000 individuals served under this ATR 3 initiative. People with depression and substance use disorders utilize medical treatment more and have higher healthcare costs than people without these disorders. Community health centers are playing an increasingly central role in providing mental health and substance abuse treatment. We need to work with them. Fragmented services, silo approaches to mental health and substance abuse result in redundancies and lack of communication. As community health centers move toward health IT, you need to be able to communicate with those community health centers and the health departments in terms of health IT. Due to the lack of insufficient training and organization, primary care physicians are not as involved, and they need to be. Emergency departments and primary care facilities are screening points. If people, that 20 million people I point out, they're not showing up at specialty treatment programs. They're not. They show up in the emergency room. They show up in primary care settings. They got hypertension. They've got diet. They got apathy. They got sleep disorders. They got everything. Doctor, help me. Nurse, help me. And nobody's asking, did you do any cocaine last night? Yeah, smoking a little marijuana. And did you look at that Coors commercial and you actually drank a six-pack in one night? Remember, they sell six-packs. What's the definition of binge drinking? 5 or more drinks on a single occasion the past 30 days. You drink a six-pack, by definition, you are a what? Binge drinker. If you six-pack on a single occasion, you're a binge drinker. So, all these people, I'm not feeling well, I show up in the emergency room, I show up at the community health center. They need to be asking questions. Large populations are seen in general medical settings, and we need to be able to deal with that. Thus, we've got Expert. It has great future potential for helping you out. Because even though the bulk of the people don't have extensive problems that require specialty treatment, the more people we screen, the more people we will see who do have. So if the referral rate is 4%, 4% of 100 is one number, 4% of 1,000 is a little larger number, 4% of 100,000 is a larger number. So screening, people say, well, screening brief intervention is not a treatment. Well, we are reaching people who we would not ordinarily reach. We have served almost 1 million people, 851,881 clients since the inception of this program. No substance use, we get people who are early in their substance misuse to stop. We're increasing employment, and this whole thing is screening, and that's what we're trying to do, and we're able to achieve that. 2010, the president budget requests $29.1 million. It's the same level. We will support 19 continuation grants, but we are working on that. Medication-assisted treatment. How many of you are using Vivitrol for alcohol? Couple. How many are using buprenorphine for opiates? A little more. We've trained 22,000 physicians. 17,000 physicians have received a waiver. 9,800 physicians, or 57% of these are in our buprenorphine physician locator. Primary care is a principal cause of the problem, yet primary care is bashful. They don't want it to be known. So we trained 17,000 physicians. Only 9,800 want to be identified as dealing with people who have addiction problems. Hello? Talk about stigma. When we do our household survey data, 81% of the people, 55% of the people who get prescription drugs get them free from friends and family. We're running around worried about the internet and drug dealers and all, and you should. But the majority of people get them free from friends and family. We have a cultural issue we have to deal with. And those people get, 81% of those get theirs from their doctor. The doctor is the unwitting drug dealer. I mean, it's a therapeutic purpose. It's not a criticism. But when we say we have a partial solution to the problem, they say, well, we don't want to see those kind of people. So the question has to be, who are those kind of people? Mrs. Jones, Mr. Smith in the waiting room. Oh, not Mr. Jones, not Miss Smith. They're fine, upstanding citizens. Well, who do you think does drugs and alcohol? People, they see these end-stage conditions and say, those are the addicts and alcoholics. Well, how did they get to be end-stage? In the beginning, they were somebody different. You don't get to be end-stage by the first use. You get to be end-stage with chronic use. And you start someplace. And they may be starting in the waiting room. So we want you to help encourage primary care physicians to be involved. We know medication treatment is effective. We know that 86% remain abstinent from illicit opiates when treated with buprenorphine. We know it's cost-effective. Every dollar spent for methadone treatment saves $12. Buprenorphine products are available to treat heroin and prescription narcotics in individuals 15 and above. We know these things.